I'm very happy to be chairing this session with Tom. Most of you probably know that it's 10 years ago now that we were all working on opposite sides of the Atlantic on separate guidelines. Miraculously, they were actually incredibly similar, although everyone concentrates on the differences between them, I think. But to come up with a positive diagnosis, both had to have the same results. It was that the route to getting there, I think, was different. But the very exciting thing now is that in 2025, we have an updated version that is transatlantic, and actually it's global. There were people from various continents on the group. So very happy to have this talk, and I'll hand over to Tom.
Okay, and I'm Tom Ferkel from University of North Carolina, Chapel Hill. It is truly my pleasure to introduce Dr. Shoemark and Dr. Horani, who led this effort, and I will tell you, it was truly an instance of herding cats. There were an awful lot of people with an awful lot of ideas, and what they were able to do in creating this guideline is nothing short of miraculous. So, with that introduction, Amelia, I'll let you start.
Oh, this is not the right talk.
Well, you can give that one too. Here we go. I'll give you this in case you want to go to the side.
Thanks. Have I sent you the wrong talk? Sorry? That's yours. Okay, good. Awesome. So, Amjad and I are going to present the guideline jointly because the whole thing is a joint ERS and ATS guideline. I'm going to start off by basically giving a background as to why we need a guideline and what tests we considered in the guideline, and then Amjad's going to give you the real thing. It should be published online today in the ERJ, so that's quite exciting. So the cats have been herded, and it should come out today. We're also presenting it at the ERS, and I just wanted to encourage people to come to that session. We're not going to give the same talk. We're going to give a different talk, but your support would be appreciated if you are able to come to that session in the ERS. So an accurate diagnosis of PCD is important, and I think for this audience, this is a bit like saying, there's a lot of bikes in Amsterdam, or like it's stating the obvious. I think we all know this and we all believe it, but I'm just going to go through it. So it's important because we can implement therapies and optimize management early. We can teach patients physiotherapy and airway clearance techniques and optimized treatment. PCD is more than just the lung disease, and it enables us to refer to our ENT, cardiology, fertility colleagues, some of whom are here, and really get patients the best multidisciplinary care they can. Identifying a gene is incredibly important in order to facilitate genetic counselling, because there are different genotype-phenotype correlations. But also excluding or trying to exclude a diagnosis is important so that we don't or do stop testing for differential diagnoses, immune deficiencies, rare CF, and reasons for those symptoms that we're seeing. And most importantly, getting an accurate, not just a diagnosis, an accurate diagnosis of PCD does change outcome. And as I said, we already know that, but there is now some growing evidence, and we need this evidence. We need that evidence to persuade the people who are funding our diagnostic tests, funding our genetics, and referring patients to our diagnostic services. So there is some increasing evidence that an early diagnosis of PCD does improve outcome. And this is a paper from the Canadian group showing FEV1 comparisons at different ages according to the age of diagnosis, and showing that FEV1 is improved if you're diagnosed at an earlier age, and then some predicted models with age for that. So an earlier diagnosis does improve outcome. And in the UK, we're doing a newborn screening research program, and we really used this paper and this evidence to push them to putting PCD on that panel of tests. So it's really important that we do have evidence for these things, and they're not just what we believe. This is an unpublished paper that Paniotis and Paniotis have kindly allowed me to show today. So this is registry data from sibling pairs. So this is 395 siblings from 21 centres participating in the ERN registry from 15 countries, 186 families. And important things that this show is that there's really a large phenotypic variability between siblings who have the same gene. So the gene isn't everything. We can also modify things beyond the genotype with treatment, with getting infections. But really one of the outcomes of this paper is showing that the lung function is better preserved in the younger sibling after adjustment for age. And that's what these graphs are showing here, as well as the predicted FEV1Z scores across life, with the younger sibling on the top in blue and the older sibling on the bottom. And it's highly likely from looking at the data that is related to the younger sibling getting an earlier accurate diagnosis and therefore earlier treatment. James highlighted this morning that diagnosis of PCD in adults is also important, and this is data from the EMBARK registry. You can see on the left-hand side here that if people have a diagnosis of PCD in a bronchiectasis clinic, they're more likely to be referred for physiotherapy, they're more likely to have their sputum sent for culture, they're more likely to have Pseudomonas eradication attempted, they're more likely to get macrolized, they're more likely to get inhaled antibiotics. So in a bronchiectasis clinic, having a PCD diagnosis is also important. Finally, and I know you already know that having a PCD diagnosis is very important, but finally, we need to make that diagnostic criteria united and accessible and accurate in order to develop the therapies we need for PCD. It's a rare disease. We need to work as an international community and all work together to the same standards and the same diagnostic criteria in order to be able to get patients into trials and get them accurately diagnosed so that we can share protocols across the world and get enough patients to be able to do these trials. So, as Jane said, there were previously an ERS and ATS guideline, we summarized shortly after the publication of the guidelines some of the similarities and differences and reasons for that, and a lot of these were methodological as well as the ways tests had been developed in different countries. One thing that the two guidelines agreed on is that a final diagnosis of PCD would be by biallelic pathogenic variants in a PCD-associated gene or a hallmark ultrastructural defect. And therefore, for the new guideline, the aim of which was to develop a unified evidence-based guideline for PCD diagnosis, for the guideline, we have used these two tests as the reference tests. So I thought I'd just talk quickly about the reference tests that we used. So the reference test is the other test that we compare everything else to in the guideline. So you can have a confirmed diagnosis of PCD if you have biallelic or, in case of X-linked, on one allele, pathogenic or likely pathogenic mutations in a PCD gene. And this list here is the PCD gene that we suggest that the list that we suggest that people use. So there's been lots of genes discovered, and the evidence as to whether they are disease-causing of PCD is very variable. So there's some genes that probably have been described in PCD and really don't cause it at all. They actually cause infertility, like DNH8, whereas there's some genes like DNH5, which we definitely know if you get a mutation in that, then that causes PCD. So this is the ClinGen project, and a group of experts for now a number of years have gone through and scored all of the evidence, and they score evidence on how many publications have been published on each of these genes, how far apart the publications are, whether they have experimental evidence as well as numerous families, and then that genetic evidence and experimental evidence is given as to whether there's strong or definitive evidence. So in one of these strong or definitive genes is diagnostic for PCD. Importantly, a negative genetic result doesn't mean PCD is excluded, as we haven't identified all the genes yet. There's variants in areas of the genes that are not looked on. There's genes that aren't looked at in some of the panels. So a negative genetic result does not mean that PCD is excluded. There's genes with low evidence. As I say, there's no genes identified. And then there's a number of results we get back which are variants of uncertain significance on one or both alleles. And in those cases, we need to do additional testing. The other confirmatory test is transmission electron microscopy. We have two types of TEM defects. So these are the class 1 defects as described in the BEAT-PCD consensus statement that many of the people in the room were involved in 2020. And these class 1 defects are outer dynein defects or inner and outer dynein defects or microtubular disorganization. And these are the classic things that we see, that when we see them, they indicate that the patient has PCD. You can also get a lot more information from TEM that gives you a hint that it's likely the person has PCD, and these are the class 2 defects. So this is when there's some outer dynein arms missing, but some are still present, when there's mislocalization of the basal bodies, which suggest that the cilia aren't forming properly, when you get an absence of the central pairs, and then translocation of the central pair, suggesting that there's a radial spoke defect. So these class 2 defects are really important because they do add to the evidence that the person has PCD, but they're not diagnostic on their own because you can see them with infection and inflammation. So they also need an additional test. And then, of course, it's the same as with genetics. If you get a negative EM result, it doesn't mean that PCD is excluded as a cause of the symptoms. So for the guideline, comparing these reference tests, we've compared 3 adjunct tests for the availability of which are available for basically making or supporting a diagnosis in those situations. The first of which being nasal nitric oxide, and Amjad's going to talk about the evidence for these tests. So I'm just going to talk about some of the things we discussed in terms of advantages and disadvantages. So low NO is the case in most patients with PCD. Measurement is non-invasive and fairly quick by aspiration of gas from the air, from the nose in a patient. It can't be done reliably in younger children because it requires velum closure maneuvers. A measurement with velum closure and chemiluminescence follows standardized methods, and the reference is in the bottom right-hand corner there for the technical standard for measuring nasal NO. And there's also the availability of electrochemical analyzers which have been developed, which do discriminate, but are less standardized at the moment. The next test we looked at is the good old high-speed video. Should have got Eric's colleague involved. This is normal ciliary beating, which I think we're all familiar with, and on the right-hand side, PCD static, and the bottom one is a DNH11 case, where you can see the tips move and the rest don't. And high-speed video is really the only diagnostic test in which you can directly visualize the primary nature of ciliary dyskinesia. And it can be determined by reproducibility of an abnormal finding after culture. So if you culture the sample, then you get rid of any infection and inflammation and influence on ciliary beating. And so it's quite reliable. It is actually relatively quick before culture because you can get same-day results, but its real weaknesses is that it requires significant expertise. It requires specialist equipment, and that really limits it to specialist centers. And it also totally lacks standardization in terms of reporting and describing what we see. And finally, immunofluorescence, which wasn't in either of the previous guidelines in terms of a recommendation. Again, not standardized, but we're working towards it. And Nikki in Heimat's lab is writing a consensus statement. It's quicker and cost-effective compared to electron microscopy, but it is dependent on different batches of antibodies and the antibodies that are selected. But it does allow you to look directly for proteins related to genes if you get a variant of unknown significance. So I'm going to hand over to Amjad to actually present the guideline, but just to acknowledge the whole guideline panel and task force, and thank you to everyone for working together so well to get an international guideline. And special thanks to Amjad, but also really special thanks to Myrona, who did an awful lot of work in herding the cats. So thank you.
Okay. So I'm very excited to present the guidelines, and thankfully, after 3 years of working on that, which at one point it appeared that it would never see the light of day, it's soon going to be out. Reviewers that are sitting in here and made my life hard and anxious the past few months, thank you as well. I can see one of them. So when we started this project, we had multiple goals. One, to try to unify the approach in Europe and the US, as potential also in the world, on how we diagnose PCD, to try to simplify the diagnostic guidelines, so not to overburden it, so it can be applicable to other parts of the world, and to try to find a unified naming scheme for patients or suspected patients. So this is the end. There are multiple tools to aid in the diagnosis of PCD. As Emilia alluded, genetic testing should be pursued whenever it's possible. This is a genetic condition, so we need to find the gene, and it's very important, especially in this era of gene therapy and precision medicine. PCD cannot be ruled out based on one negative test. Super important. And to confirm PCD, either a genetic test or classical changes on electron microscopy are needed. So, when should a patient be referred for diagnosis? And we think that if you suspect PCD, you should refer the patient for diagnosis. There's multiple guidelines out there. We decided not to choose one specific one. So in North America, we like the Lee criteria of chronic cough, nasal congestion, sinus abnormalities, and neonatal respiratory distress. 2 and more of those is highly suspicious of PCD, but sometimes even 1. In Europe, PICADAR scoring is used. Just note that if the patient doesn't have chronic cough, PICADAR doesn't work as well. So if you can start either way. You can even use the bronchiectasis guidelines to decide that this patient doesn't fit the classical idiopathic bronchiectasis patient and potentially need to be referred for further diagnosis. Multiple tests, as Emilia have suggested, and we aim to look at which test can fit in this diagnostic guidelines when compared to either electron microscopy or genetics as reference tests. So we had 3 PICO questions, which were tested using grade, and we had some narrative questions, 3 narrative questions that we deemed very important to discuss in the paper, and which I would discuss briefly here. So the first one is, should patients suspected for PCD be tested with nasal nitric oxide in addition to electron microscopy and or genetics? Should patients suspected for PCD be tested with cellular beat pattern assessment using high-speed video microscopy? Again, in addition to electron microscopy and or genetics. This is one of my patients with a variant in LRC6, and you can see how the cilia are completely immotile. Should patients be tested with immunofluorescence in addition to electron microscopy and or genetics? And we have 3 narrative questions. The first one was, what are the clinical manifestations in patients with PCD across the lifespan from birth to old age? What additional diagnostic tests could potentially find their way into clinical practice? So tools that are currently more used in research. And the third one is, how can we overcome challenges in diagnosis in resource-limited areas? And the resource-limited area is not necessarily a country which is a developing country, but areas that have limited access to technology or expertise. So rural area in the US can fit a limited resource area. We looked at all studies that were published in any language between 2008 and 2015, so capturing the last 15 years of PCD research. We looked at consecutive studies that looked at consecutive patients that we referred for PCD testing. These should be either clinical cohorts, randomized trials, or case series. And the paper should have discussed both the index test as well as the confirmatory test, either genetics or electron microscopy. We did exclude testing that didn't look at PCD, which is obvious. Narrative reviews, case series, or controls that only looked at PCD patients, so didn't have the control part. We excluded the studies that had less than 5 patients in them, or tests that didn't really describe the electron microscopy, genetics, or index test in enough details to make assessment of bias. We started with a lot of papers, 4,842 papers. Up front, we excluded a lot of them, about 2,000. We ended up screening about 2,900 papers. And of those, only 412 papers were reviewed using full text. And after all this extensive review, you can see that the numbers fell significantly. Only 8 papers fit PICO 1, 8 PICO 2, and 2 PICO 3. The narratives had slightly more because they were not used with grades. So we had 11 and 11 for the first 2 questions and 6 for the third question. So for PICO 1, which looked at nasal nitric oxide measurement, we ended up dividing that questions into 2 parts. Since with nasal nitric oxide, the testing can be done with a venom closure, which it fits older individuals, or with tidal breathing in younger kids. There were 5 studies for the first part that did not have serious risk of bias, with good sensitivity of 93% and high specificity of 88%. And the panel recommends the use of nasal nitric oxide in the diagnostic pathway for PCD. There's a strong recommendation for this intervention and with moderate certainty of evidence. If we use tidal breathing, then although the sensitivity is still relatively okay, 77%, the specificity significantly drops to almost 57%. So we only suggest using nasal nitric oxide measurement with tidal breathing for PCD diagnosis. It is still informative, but it can have some accuracy issues. This is a conditional recommendation with very low certainty of evidence. I should note that a normal nasal nitric oxide measurement does not exclude PCD, so it should not be used as a standalone test for PCD diagnosis. A positive test can support the diagnosis of PCD, so it doesn't necessarily confirm it, but support it. For younger patients, as I mentioned, unable to use venom closure, we can get some information from tidal breathing, but the accuracy drops significantly. Nasal nitric oxide measurement should be done in a place that knows how to do the test, so that follows the published ATS or ERS guidelines for performing the test, and that have the updated equipment and knows how to interpret the test. For the second question of whether we can use high-speed video microscopy, we had 8 studies. 4 of them were done post-culture, meaning that the sample was collected from the airway, was allowed to recover, so secondary changes potentially would not affect the culture. And those had a low risk of bias, with excellent sensitivity of 92% of identifying PCD and high specificity of 98%. We also had 5 studies that used pre-culture, meaning that sample was collected fresh and evaluated right away. The sensitivity was still good at 97%. However, as you can see, the specificity falls to 80%. We did look at this specific question with all the studies together. So there's a recommendation to use a cellular beat pattern assessment in the diagnostic pathway. There's a strong recommendation for this intervention, but very low certainty of evidence driven by the pre-culture data. Similar to NO, a normal ciliary pattern analysis does not exclude the diagnosis of PCD and therefore should never be used as a standalone test for diagnosis. A positive test does support it, doesn't confirm it, but supports the diagnosis of PCD if in concordance with other tests. The panel does recommend using post-cultural analysis whenever possible because it's more specific and more sensitive. But again, as Emilia mentioned, there does require a lot of expertise. So, and the panel cautions that if you're going to use high-speed video microscopy in your diagnostic pathway, you should be a center that has high put of high-speed video microscopy, have the expertise, have the equipment, have the high-speed video camera, and potentially have the ability to culture your cells. The third question is whether we can use IF. These are beautiful images from, I'm biased, so these are my images. This is HEAT-R2, which we worked on many, many years ago. We continue to work on one of the adenine assembly factors shown in red. But the picture on my left side, your right side, shows how powerful IF can be. If it's missing and can really aid in the diagnosis. This is a patient with a variant in HEAT-R2. We had only 2 studies that met the inclusion criteria, and we are deemed with low risk. About 324 patients that were evaluated, excellent sensitivity, 84 to 88%, very high specificity of 100%, but there were some inconclusive results driven by the antibodies that were used. There's a recommendation to use IF in the diagnostic pathway. There's strong recommendation, and we feel high certainty of evidence. But similar to the other recommendations, it does not exclude PCD, and therefore should not be used as a standalone test. A positive test, again, can support the diagnosis of PCD if in concordance with other tests. Again, it doesn't confirm it, but supports it. The collection, the analysis should be done in a laboratory that does know how to do IF, that has high throughput of IF, and a place that will be able to test batch-to-batch differences with the antibodies. These antibodies coming from companies can have variation in their ability to detect their targets. So it should be done in a laboratory that does know how to do IF. For the narrative questions, there were no surprises. The papers describe the typical symptoms that we often see with PCD, so I'm not going to go over all of them. Hydrocephalus is coming again and again, especially with specific mutations. So if you have a patient with hydrocephalus and chronic cough or nasal congestion, do think about primary cell dyskinesia. For narrative 2, these are the tests. Most of them are genetic. So whole exome sequencing, especially with long read, there's a relatively recent paper describing how you can pick even more variants in genes known to cause PCD if you go and use long read sequencing that are missed on the regular whole exome sequencing, definitely missed on panel analysis. RNA sequencing, which is mostly used for research, can potentially be used to detect changes in mRNA level and suggest abnormalities in the gene. Nebulized albumin colloid, which is done in a couple of places in Europe, maybe more. 1 place in the US, 5 places in the US, excluding WashU. We need to get that machine. Targeted sequencing, especially when there's founder mutation. This is an excellent tool, especially if you're a resource-limited area and you know that you're only dealing with 1 mutation, so you can bring your cost really down. And whole genome sequencing, which my guess over the next few years, it will probably supersede whole exome sequencing as the diagnostic tool of choice. Narrative 3 question is how we can overcome challenges. And there were 6 papers. 2 of them were very explain the details, their approach, and the suggestions that we could pull from these papers. That 1, use a tool to screen your patients. We cannot test every single patient that come with cough. So we need to start somewhere, and the PICADR scoring is an excellent tool to start, as well as there is a scoring criteria. We realize that not every place is able to do every test. So the best way is to try to partner with a place that does know how to do these tests, whether it's national or international. Many of the big places are more than happy to do genetics or look at genetic data, or if you ship them IF to do some of these tests. And I think this is the way to go. You don't need to do everything in your center or your country. Targeted sequencing for founder variants. I have colleagues that were able to bring the cost to about $10 for a single gene, and they know that all the suspected patients coming from specific families, because of the consanguinity within that group, have that gene. So versus doing several $1,000s for whole exome sequencing. There are specific concerns that were raised with some of the papers. Inadequate insurance coverage, especially in places that have money to cover, which is a problem. Insurance, I don't know if there are insurance representatives here, but they should cover genetic testing for those patients. Problems with national funding, as you heard in the news, these are in some places are being cut. There are concerns of barriers to care, either because of political unrest or ethnic issues in some regions where people need to cross barricades, or they don't have the adequate infrastructure for those testings. The recommendation. So if you have a patient suspected of PCD, they should be referred to a diagnostic center whenever possible, a PCD center. If that is not feasible because there's no PCD center in that country or in that region, then we recommend that practitioners should partner with a place, the formal PCD center that can at least provide some advice, whether send the patient there or send the sample there, or at least call them and talk to them and discuss your result. Cases cannot be confirmed without a reference test. You need genetics and you need TEM. I'm biased for genetics, and we think that genetics is the way to go in a genetic condition. But if genetics is really can't be done, then at least electron microscopy. Without that, you cannot confirm PCD. So, which test to start with? Whatever test is accessible to you. You can start however you like, either with nasal nitric oxide, high-speed video microscopy, or IF. But again, you need to partner that with either genetics or electron microscopy. If you have two pathogenic variants or likely pathogenic variants in a PCD, non-PCD gene with a strong evidence for disease causation, example DNH5, and or TM cross-sections with class 1 defects, and this is PCD. You can confirm that this patient is a confirmed PCD. And again, as I mentioned, the preference is for genetics. If you have variants of unknown significance in one or both alleles, or two pathogenic or likely pathogenic variants in a known PCD gene with moderate evidence for disease causation, and one or more positive tests, so electron microscopy, high-speed video microscopy, or IF, and concordance with the expected phenotype and expected inheritance, that then these patients cannot be confirmed PCD, but they are highly likely PCD. And this is the term we suggest you use. If this is a patient with an electron microscopy with a class 2 defect and one or more tests that is positive, and the test results are concordant with the known inheritance and the phenotype association, then again, this patient can be called highly likely PCD. Again, not confirmed PCD, but highly likely PCD. These patients probably should be retested in the future. Maybe the evidence will change, especially the genetic evidence, and they can be upgraded to confirmed PCD at that time. If the patient has one or more negative tests, that is, you do multiple tests and high-speed video microscopy is normal, or nasal nitric oxide is above the cutoff, and there's a negative genetics or negative transmission to electron microscopy, and highly suspicion for PCD, that is, they have two or more of the symptoms that we see with patients, which are situs inversus totalis, or bronchiectasis, neonatal respiratory distress, chronic, lifelong chronic cough, and or upper and lower airway symptoms, then these patients should be designated suspected PCD. And the reason for this terminology, so that they can get the care, and then you can re-evaluate them again in the future to see if you can upgrade them to highly likely or confirmed. If the tests are inconclusive and conflicting, and there are negative genetics and negative electron microscopy, and the low clinical suspicion, only one symptoms, then these PCD patients are unlikely. Similarly, if one or more negative tests and negative genetics and negative TM and low suspicion, then these patients are probably PCD highly unlikely. You notice that we didn't say excluded because it's very hard to exclude patients with PCD if they do have symptoms. These patients should be re-evaluated in the future to see if the evidence change, if the symptoms change. It's easier to confirm, but it's very hard to exclude in a rare condition. Okay, so another summary slide. No one test can rule out PCD if patients have compatible symptoms. Okay, even genetic tests, because as Emilia mentioned, we know many of the genes, but not all of them. To diagnose PCD, a positive genetic test and or class 1 transmission electron microscopy is required, and the preference is for genetic tests. And multiple positive tests, reference or index, increase the likelihood of PCD. And this is the list of the wonderful people I had to work with over the past 3 years. Thank you, thank you, thank you for making my life relatively easy. Thanks.
So we have 3 case scenarios to kind of go through this process. And at the end of those, I think we'll open it up for questions.
Thank you. The first cases are going to be presented by Panagiotis Kouis, who was a member of the ERS task force in the first time round and of the ATS ERS guidelines this time round. And I think you'll have about 10 minutes.
All right, thank you. Good morning, everybody. So the goal of this presentation is to show some interesting cases, but mainly to see how putting these guidelines looks like in real life diagnostic situations. You have this. How do you go forward?
You were asking the wrong person.
Yeah. This one. Okay. Great. Right. So the first presentation was an index case of a family of 3 PCD siblings. So the first index case was a female. She was 6.5 years old at the time. She was very typical PCD case, clinically chronic wet cough, history of NRDS, history of pneumonias, ear infection. She needed grommets. She was cytosolitis though. Afterwards, we also invited her 2 siblings, 2 females, a bit older. They were teenagers. They were very mild in terms of PCD symptoms, and they were very variable during their lifetime. Also cytosolitis, and quoting the clinicians investigating the case, it was like you wouldn't believe that they had PCD. Now, all 3 siblings, at the time that they were invited for testing, they had the 3 adjunct PCD diagnostic tests, nasal and NO, carried out with a chemiluminescence analyzer, high-speed video microscopy, carried out on primary cells, no culture, using the SAVA system for ciliary beat frequency and ciliary beat pattern determination, and of course, TEM. We still don't have IF at our lab. So these were the 2 adjunct tests, and we have TEM, but we didn't have genetics at the time. And this is how their results looked. And these are results that are confirmed more than 2 times for each individual. So they had repeated nasal brushings. The index case, she had abnormal nasal NO at 41 nanoliters per minute. Her high speed was rotational, and her TEM was class 2 defect central pair. The high-speed video microscopy and TEM were similar in the other 2 siblings. Nasal NO was normal. Still relatively low, but above the cutoff of 77 nanoliters per minute that is considered diagnostic for PCD. These are their TEMs. On the left side, you can see a normal control sample that you can see the well-known 9+2 ultrastructure. And you see the cases that we had in approximately 40% of the examined cross-sections. And I'm talking about repeated brushings here. So we did see a lot of cross-sections. We had these missing central pair defects, and very, very sparsely, we did find one peripheral microtubule going into the middle. So it was still not, we were not able to classify it as an INDA plus microtubular disorganization class 1 defect. So it remained a class 2 defect with a central pair defect. And their INDAs and ODA were assessed as normal. This is a normal high-speed microscopy sample, and this is case 1 and case 3, the index case, and one of her sisters. So there are two different systems, a newer one, the Sava system, and an older one that we had, and you can see that you don't have direction in the beating, that you have these rotational patterns. So at the time of investigation, based on these results, we have class 2 defect supported by abnormal high-speed microscopy and low nasal NO at least for one case. So based on the current ERS ATS guideline, this decision will be that this is a PCD highly likely case. Afterwards, approximately 10 years later, we had availability of genetic testing. We carried out genetics. We revealed homozygous mutation in our RSPH9, which is in agreement with our diagnostic phenotypes. It was a novel mutation, but in silico models predicted as pathogenic. So based on the same guideline, now these cases can be reclassified as confirmed PCD. Seeing as example specific recommendations from the guideline, you can see that, for example, a normal NO result does not exclude PCD and should not be used as a standalone diagnostic test. This applies in our case. If we have used it, we will have missed case 2 and 3 if we have used nasal NO alone. A positive NO result can support a diagnosis of PCD in concordance with other tests. For the index case, that we had a bit of mismatch or uncertainty based on our findings, having also the NO really convinced us, and we invited the siblings as well. A positive high-speed test result can support diagnosis of PCD if in concordance with other tests, and in this case, it was a very strong indicator that we were right on the right track for the diagnosis. And when diagnosis cannot be confirmed using genetics or TEM, additional tests are needed. Not all are required. In our case, we didn't have IF. However, limiting the number of tests conducted may impact diagnostic accuracy. And that's the case in our situation, because if we did not have high-speed microscopy down from 3 to 2, then we would have missed some of these cases. Now, a second presentation, much shorter and also more recent, a case that came to our clinic. It was 10 months old. It had typical PCD manifestation, NRDS, chronic wet cough, chronic rhinitis, and had situs inversus totalis. It underwent the same diagnostic test that we have previously available, but also this time we had a whole exome sequencing for genetics. The result was abnormally low NO because it was a young child. It was tidal breathing, and we used a mean of 3 peaks at the time, 11.5, so that's abnormal. The high-speed video microscopy showed majority motile cilia, but there were some with residual movement, and TEM was class 1 defect, out and DNR defect. We also did genetics, and that were uncertain because it was a missense variant in DNH11, a homozygous missense variant that was classified as VUS. And although some in silico tools predicted it to be disease-causing, formally it wouldn't be disease-causing with the ACMG criteria. This is the diagnostic test from this child we have outer DNA defect in the TEM, and we have a clearly abnormal high-speed video microscopy with a lot of the sample being immotile. Taken together, this case shows that we were able to establish a definite PCD diagnosis because we had TEM class 1 defect, even in the presence of uncertain genetics. So although genetics is the way forward, as Amjad said, there is still room for additional genes maybe, or we will have cases with variants of unknown significance, and these tests can also, these adjunct tests can also support diagnosis when genetics do not. We have concordance in our findings between high-speed video microscopy and nasal NO and TEM, and this confirms our certainty, but we have mismatch between our genetics and our diagnostic phenotype. So that means that we still need to do further genetic workup, maybe to see what is the genetic variant causing this case. And with this, I would like to thank our team at Cyprus that has been working all these years and diagnosing these cases. And thank you for your attention.
Okay, our next two presenters are Dr. Hirst and Dr. Patel. Is this a tag team?
It's a tag team.
Okay.
The tag team, Tom. Thanks, guys. Deepa's important because she's the clinical lead here. So we're going to do a clinical and a non-clinical double act.
Hi, everyone. So, yeah, Rob and I will talk a little bit about PCD diagnosis in practice for using some real-life cases. How do we move this slide? There we go. So a quick slide to show that we collaborate quite closely with our other centres, and that was highlighted in the presentation of the guidelines. And actually, these collaborations are quite important across the patch we cover, because at Leicester we are the centre that has a high throughput of patients that come through, and therefore provide the expertise for any cases that are referred in for diagnostic assessments. And the graph to the right, what you can see there is how many patients we have with diagnosis of PCD in the last year versus the blue who had essentially normal results. So case one, this is really to highlight that all tests are not needed. So this was a 37-year-old lady who had neonatal symptoms, oxygen at birth, bilateral polyps, and chronic rhinitis from as long as she could remember. The only slight odd part of the presentation was that it was a relatively late onset cough at the age of 15 years. And if we were to use the PCD, or the assessment to screen this through, this wouldn't typically fit. She did, however, have a history of bronchiectasis and had grommets as a child. So as per the guidelines, we proceeded to undertake a nasal nitric oxide. And at Leicester, we use a chemoluminescence using a breath hold procedure with a tidal flow of 2 liters per minute. And what you can see here is from the right nostril, slightly higher values than the left, but even so, the nasal nitric oxide was low. And I'll hand over to Rob.
So we did 2 biopsies on this patient. Both of them were stuffed full of bacteria, which I hope you saw there. So ongoing infection, no cilia in the sample, means it's a difficult case to start with. So I don't know why they're not playing. Oh, they are. Okay, so that's the normal at the top. That's what we expect. And after ALI culture, this index case showed static cilia, completely static cilia. So it showed the benefit of using the ALI culture method. Rebecca did this in the lab. She sat up there. This is the immunohistochemistry from the patient, showing that we saw an absence in the culture of DNA H5. So this is now starting to look suspicious. We then got the genetics back, and it showed a pathogenic compound heterozygous in DNA H5. So To summarize this case, it's low NO, but the polyposis we think might be affecting the transnasal airflow, which means we get uneven measurements on each side of the nostrils. There was no cilia on repeated biopsy due to infection. And again, we need to think about the infection, as James spoke about this morning. And the culture really came to the rescue in this patient on one level, because we could see a functional effect on a lack of H5 in IHC and no movement in the cilia in high-speed video. So we stopped there when we got the genetics back, because TEM wasn't needed. We could confidently say that this patient had PCD.
Thanks, Rob. So we'll move on to case 2 now. So, as you can see, a genetically inconclusive PCD, and we'll talk through the history again. So this was a 1-year-old girl who was referred in for what sounds like a very high clinical history of situs inversus, VSD, chronic rhinitis, a wet-sounding cough from birth, and glue ear. Again, at Leicester, we often struggle with the tidal breathing method for the nasal nitric oxide, and partly that's due to the issues already mentioned for accuracy by Amjad earlier. So we did not undertake this, and we moved on.
So in the lab, all the tests failed. This is a classic difficult case. So the high-speed video showed no cilia at all. And the culture failed, so we couldn't really be any wiser. Then we got the genetics back, which was really helpful. No pathogenic variants detected. So we've got a really, really strong clinical history. So we needed to repeat the brush biopsy. So the baby came back 5 months later with a healthy epithelium, well ciliated, and they're all static. There was a few twitching at 3 hertz, 100% were abnormal. And the TEM came back as a truncated outer dining arms at 100%. Again, this is a class 1 defect by the international guidelines. So this is a case where genetics really didn't help as much. So in summary, this one I think is a clear PCD positive case by high-speed video, a TEM, which is class 1, and a very strong clinical history. And Deepa's looking after this patient now in the management centre at Leicester. Immunohistochemistry and cell culture we didn't think was needed anymore, because we've got a strong battery of test results back. What we can't rule out, though, is the genetics, because it was a panel. So we can't rule out VUSs, intronic variants, or is this a new gene? So we're going to treat the patient anyway, and then repeat the genetics in future. So I think from the guidelines for me, I mean, we talk about genetics ruling in the diagnosis of PCD, but over the last 4 years, I've been capturing the data from ClinVar on 2 of the big genes, DNAH5 and H11. You can see the green line is the variants of unknown significance and the benign cases. And there are over, nearly, we're looking at about 8,000 variants. Of those within that gene, there is, only about 1,000 that we know are pathogenic. And I know that I've been working with the ClinGen team, with Hannah and others, and Amelia, and I think Hannah's going to speak more about this later, the difficulties that we have. The structure function tests we hope will be able to elevate some of the pathogenic, the VUSs to pathogenic. 1 in 3 patients, though, still do not get a diagnosis of PCD. We're now starting to see some of the consanguineous families, certainly in the Leeds cohort, which Evie and Julia look after. They have multiple PCD genes in individuals, and some now even can have CFTR mutations as well as a PCD gene. So we also don't know about the unknown genes, of course. So I finish by thanking the team, 2 of which are in the audience, Rebecca and Anya. And with that, I'll hand over back to the chairs.
Nice job. Okay, don't run away too far. And the speakers, Amjad and Amelia, I'm sure this was perfectly clear and there was absolutely no questions regarding the guidelines. If you do, now's your opportunity. Yeah, what we hear?
I have a microphone. Sorry for it. No, well, one remark about the guideline. I mean, PCD is a very heterogeneous disease, and often you need a full diagnostic panel in order to make a diagnosis. You were talking about a lot of things like sensitivity and specificity, as if it's one disease with one sensitivity, one specificity. But for example, DNH11 has normal TEM. So if you have a reference population with a lot of DNH11, then your sensitivity specificity of TEM is very bad. And the other way around, for genetics, you often, like you mentioned, you often have variants unknown significance. For that, you need your valid functional validation. Well, my question would be, how did you handle the sensitivity and specificity issues? Were they based on all the previous literature, like for example in NO that was based in the American studies predominantly on TEM positive and genetically confirmed patients, excluding of course all the patients with normal TEM and more recently discovered genetic defects. How did you handle that in your study? Did you take that into account, or were the numbers used in the previous studies?
The methodological questions go to me, I see. I think this is a very valid point, and it would be actually wonderful if there were more published data on consecutive referrals of people on specific genetic defects so that we could account for that. But the published literature, as Amjad showed, it was very little for most of the index texts. So 8 papers for nasal NO and high-speed video microscopy and only 2 for IF. So this was not possible. So our reference test was either TEM class 1 defects or disease-causing known PCD genes over the past 15 years. So that's also already a heterogeneous period for genetic analysis and genetic testing. And we had to make a decision of what we will compare with the sensitivity and specificity. And this is the overall sensitivity and specificity of the test, without accounting that in specific cases of patients, this might be different.
Yeah. From that respect, one might argue that you actually should not determine things like sensitivity and specificity on the whole group, because it's really heterogeneous. And like, for example, when you take only patients with confirmed TEM and genetics, you exclude a lot of patients.
I will be very practical here. The ERS and the ATS have very standard criteria about guideline development from a methodology point of view, and we need to follow some specific methodology. Otherwise, it is possible that we sit down together and, like experts of diagnostic tests, they discuss and they make a decision and they develop some recommendations based on that. So the decision that we wanted to do it with the support of the ERS and the ATS, that I think it will help also with the guideline to be more adopted also outside of our network, which I think it's very important for people to know to refer people for expert diagnostic testing, led us to to choose and follow a specific methodology. But I do agree and I understand the arguments, Eric.
Can I just add that we did not look at the sensitivity and the specificity of the reference tests in this procedure. So we didn't look at the sensitivity and specificity of TEM, and we didn't look at the sensitivity and specificity of genetics. And we have to use those reference tests because we have no other.
Next question is up here.
Hi, Amelia. While you're standing there, just
hi, Mike.
hello. Just with regards to the sort of point of clarification, and Amjad as well, for the suspected PCD section, it started off by saying one or more negative tests, which I read as they can all be negative. I'm
just going to interrupt. That's supposed to read positive, and it reads positive in the manuscript.
Oh, okay. So. Right. That makes the next bit. Yeah. I'm glad I clarified that because it makes the next bit irrelevant.
Okay. Yeah, thank you for this nice presentation and all the presentations. I think one thing I was wondering was, there's always this delay in getting the genetic resource, and sometimes you cannot get it, and you put it on a watch list or whatever you do. What is the practical way of doing this, returning to repeated genetic testing? How do you manage that? Anyone?
Can you repeat the question? I missed it, sorry.
When do you go back and repeat the genetic test? That's a short question.
So that's a good question. I mean, we did not specify a timeline, but if there's a patient with high suspicion based on clinical criteria and you can't confirm it using genetics or TM, then my practice is to bring the patient again every few months and reevaluate the data again. Obviously, we will not repeat the genetics every 3 months because you will not have new genes. But if there's 3-4 genes that have been identified in that interim, then maybe it is time to repeat genetics. It's a tough question. In many cases, if you have, we do a lot of our fair share of whole exome sequencing, so we can just go back and pull the data again and reevaluate it, which is relatively easy. Panels are a bit harder.
Could we just pass to Debbie to answer on my behalf? Sorry, Debbie does the genetic testing in our centre, and I suspect her comment was related to that last question.
Claire could probably answer it as well. I think that the addition of new genes is obviously great, but the other thing is just the technical development. So I would say it depends on what test you've had. If there's a more comprehensive test available, for example, going from a panel to whole exome or from whole exome to whole genome, and possibly in the future, whole genome short read to whole genome long read, that's the indication for then going to the next test.
Dr. Hirst?
Yeah, I mean, I think this is where I picked up a few of the problems, Amjad, really. I think that if we look back at the timeline for diagnosing our patients, early days we had 15 gene panels, and then we had 40 gene panels, then we got 60 gene. So with Deborah, I think that being able to turn these tests around quickly is a big thing. And in the future, we will need to revisit some of these already diagnosed patients because of potential additional genes that we find later in the future.
So if this is a patient that you already confirmed genetics and it fits the clinic, then you probably don't need to do that. But if this is a patient diagnosed with TM, yeah, I think we need to go back and get genetics. We need to pursue a confirmed genetic diagnosis on all patients. This is, again, we didn't, in those guidelines, we didn't say firmly get genetics because otherwise some places won't be able to ever confirm PCD. But we need to confirm, I think we need to get genetics on all patients.
Okay, 2 questions.
I'm just curious to the method is used for collecting the samples for the biopsies.
Yeah, so we don't give a recommended methods. We don't make any recommendations on methodology beyond it being an expert centre. But most of the centres, the experts that were in the panel, use nasal brushings.
Yeah, but that is a great observation that Amelia had mentioned. A lot of these things, while we think they're going to be very useful and they're included in the guideline, we need to standardize them so the process is the same every place in the world who are trying to do these assays. And you have the last question, ma'am.
Thank you very much. Claire Jackson, Southampton, and I'm leading the Work Package 7 Diagnostics. I just want to put a shout out to the Slack platform that we have. Amjad recommended cross-connection to our colleagues who have these expensive or more complex tests, and you're welcome to sign up. If you go to the homepage of BEAT-PCD, you can sign up to the Slack platform and highlight your difficulties, and we can help connect you to other experts. And I echo the fact that once you get you go to your tests, your array of tests, but you have your genetic analysis, it's so important that it has to be applied in context to the functional tests for you to look for the specific patterns that allow you to make a firmer diagnosis or, more confidently highlight highly likely PCD and not to exclude too quickly.
And forgive me, Dr. Omran being Dr. Omran. That's the last question.
I wanted to make first a comment. I think it's really great what you did. Yeah, I mean, because many people were asking, I think you did a really good job. And what I really also like is that you also tried to comment what's happening in, let's say, countries where you do not have all the money to do all those complicated tests. And I think what we learned from the last time is that this is a guideline that is already a little bit outdated, and then we are working on the next. And I think this is a normal way. And I think this is how we go and how we try to improve. And I think you are doing a really good job. Many thanks.
Yes, by all means. Clearly, this is not the first guidelines, but I'll guarantee you they're not the last. So thank you very much. We're going to see to
Thank you so much. So we're moving to the next session. My name is Dr. Wilfredo Jesus. I'm a pediatric pulmonologist in Puerto Rico. I'm happy to share this session with Dr. Gutaki about the consensus management statements.
We're running a few minutes late, but I hope that you can all be a bit patient before lunch. I think this is an excellent opportunity. Whoever was last year at our meeting, we did a public consultation for this consensus statement about the management of PCD. And now Elora Peulier-Maitre is here to present us the final results of this Delphi process of our consensus statement. Thank you very much, Elora.
Thank you. Hello, my name is Elora Peulier-Maitre. I am a pediatric pulmonologist in Paris, and I am a member of Work Package 8. And I'm very glad to share with you the collective work we have made that aims to get an international consensus statement for management of PCD clinical care. So our work focuses on standardization of clinical management in PCD. And the last ERS task force on the subject was published in 2009. And despite few clinical trials in PCD, recent advances were found, for example, azithromycin therapy or other anti-infectious strategies. And it seemed important to us to update consensus statement. Thank you. It seemed important to us to be able to update this last ERS task force with a consensus statement for the clinical management of PCD. And given the fact there are few studies with high evidence, high-level evidence in PCD, the best way to do that seemed to us to have a consensus statement based on current evidence and expert opinions. So compared to the ERS task force of 2009, it seemed important to have a multidisciplinary panel with pediatric pulmonologists, physiotherapists, ENT specialists, patient representatives, and pulmonologists. So we had a core group that was constituted with the members of the Work Package 8, and their role was to review the statements, to reformulate them, and to analyze experts' feedback. 30 experts agreed to participate to our study. So as I said, it was a multidisciplinary panel, and they came from 16 different countries. And it seemed important to us to include some experts from North America, South America, and Australia as well. So we used the Delphi method to achieve this consensus, and we conducted several rounds to reach consensus. The statements were proposed to experts with a Likert scale, and they could grade their level of agreement from 1 to 5, 1 being not agree at all with the statement, and 5 being totally agree with this statement. It started in April 2024 with a first video meeting to review the former task force and to get comments from the participant and to be able to know what elements really matter for the new consensus statement. The first round was held in summer 2024, and last year in Vienna, we had a discussion about these first results to be able to improve again the statements. We had the second and then the third round in last spring, and now we have 63 validated statements, even though several subjects didn't find any consensus. This is the outline of the consensus statement. So we have several parts. The first one is about general information. The second part is about respiratory treatment, and we had subsections with airway clearance, infection management, inhalation therapy, other respiratory treatment, preventive care. The third part was about ENT treatments. We had a part about other organ systems, and the fifth part is about follow-up. So for the first round, we had 74 statements submitted and 50 were validated. For the second round, we submitted 19 new statements and we had 11 validated this time. And for the last round, the third one, we had 5 new statements and 2 were validated. So in total, we now have 63 statements. I will not be able to show you all the statements, but I will show you an illustrative selection of consensus statements and updates. And compared to the 2009 ERS task force, the new statements are marked with a red star. We reformulated the statements for the ERS task force, but for example, in the part general information, these 2 statements were already present in the ERS task force from 2009. So for example, we reached consensus that every effort should be made to make the diagnosis of PCD early according to international guidelines and start treatment as soon as possible. We also suggest people with PCD should be seen for either full or shared care in an adult or pediatric center specializing in bronchiectasis or chronic suppurative diseases. Concerning respiratory treatment, a little focus on airway clearance. We suggest airway clearance by combinations of physiotherapy techniques and physical exercise should be encouraged. And we had 2 new statements that we suggest to consider the use of mucoactive treatment in people with PCD who have difficulty in expiratory sputum and poor quality of life, and where standard airway clearance techniques have failed to control symptoms. And we add that, for example, nebulized hypertonic saline is often used and has been shown to be safe. We also add a statement to say that considering there is no existing evidence specifically for PCD, this approach should be individually reassessed in consultation with a physiotherapist. Concerning infection management, we reached consensus to say that we suggest performing a respiratory culture in case of a pulmonary exacerbation, that for people with PCD, considering the most likely bacterial pathogens, amoxicillin clavulanate can be used as a first-line treatment if there is no known colonization, and that the first-line treatment can be adapted according to the patient's previous microbiology results and as soon as possible adapted based on current respiratory cultures. Still in infection management, we agreed that we suggest screening for Pseudomonas aeruginosa during every routine sputum examination, and that whenever there is a new isolate of Pseudomonas aeruginosa, we suggest eradication therapy for children and adults with PCD. We also recommend azithromycin maintenance therapy to be used for people with PCD presenting frequent exacerbations and needing repeated course of oral antibiotics. Concerning inhalation therapy, there are already statements in the ERS task force that we rewrite here, and mostly experts agreed to say that we recommend documentation of reversibility of airflow obstruction to be performed, and that we recommend inhaled bronchodilator therapy and inhaled corticosteroids therapy not to be routinely given to all patients. Concerning other treatment, just to give you an example, we have these statements where experts agreed to say we don't recommend lobectomy surgery except in exceptional circumstances and after multidisciplinary team consultation. Concerning ENT treatments, there are several statements. I put here only two, but we agreed that patients should be referred for ENT evaluation shortly after diagnosis, even in case of non-prominent ENT symptomatology, and also that pulmonologists should be attentive to identify problems which might require specific ENT intervention, and refer patients to ENT specialists in these cases, even outside of regular follow-up. Concerning other organ systems, there were a lot of new statements experts agreed on this section. For example, that situs abnormalities should be investigated, that we suggest a systematic abdominal ultrasound for associated structural abdominal malformations could be done at diagnosis. And as a part of the transition process from pediatric to adult care, we suggest to discuss fertility with male and female patients and consider early referral to fertility centers when appropriate. Also, we had a statement to say that according to genotype, extra-respiratory manifestations should be investigated, and we will develop it in the text. Concerning follow-up, a few more statements. For example, experts agreed to say that we suggest to perform a respiratory microbiology culture at every routine examination. And so we agreed to say that it would be 1 to 4 times a year or more frequently in case of clinical exacerbation. We also suggest to evaluate lung function at every routine examination or more frequently in case of clinical deterioration or exacerbation. Concerning follow-up, still, we recommend multidisciplinary follow-up, including adult or pediatric pulmonologists, ENT specialists, dietitian, physiotherapists, nurse, and psychologist. And we suggest people with PCD should benefit from therapeutic education programs throughout their follow-up, from childhood to adulthood. There were some statements and some subjects that did not reach consensus. For example, we did not find a definition for respiratory exacerbation or for what is frequent exacerbation. And we did not find a consensus on a standardized management for Pseudomonas aeruginosa isolation. And also we did not find a standardized management for one microorganism isolation without an exacerbation. Also, we did not find a precise timing for radiological follow-up, neither the role of MRI. With this work, we developed new 2005 consensus statement for the management and follow-up of patients with PCD, and we have a total of 63 statements validated. We also have a broader range of management options informed with authors' comments, and thanks to this consensus, we can hope for a greater standardization of practices across pulmonology centers. However, some key topics did not reach consensus, and so it requires further discussion. Thank you very much for your attention.
We have time for 3 questions. I have Dr. You? Yeah. Thomas.
Very nice job. One of the aspects of, I'm sorry. Very nice job. But what this does, really, it highlights exactly what Kim said earlier on when he was talking about the Center for Clinical Trial, or the Network for Clinical Trials. It's great to have a consensus of people agreeing. It'd be even better to have evidence. Thank you.
We have one question.
Yeah, I was a bit worried about the statement on sampling frequency. Could you repeat that?
On what, sorry?
Sampling frequency, culture, visits, number of yearly cultures.
Yes, 1 to 4 times a year. There were many discussions between pulmonologists and pediatric pulmonologists, and according to centers, the number of visits per year could change a lot. So we finally agreed to say at every routine visit, but we did not agree on a specific number of visits a year for people with PCD.
it's very interesting because this is really the problem with these surveys and statements, because we have already in between us within BEAT-PCD and ERN a statement on the number of yearly sampling. We would like to have 4. And that was 30 people, just a bit older than those people sitting in this survey round. So it's, are we going down in number now, or how should we interpret this? I'm just a little worried.
It is not so much a reply, it's a comment, Kim. I totally agree, and we discussed about the consensus. Of course, it came up in the discussions. It is quite difficult to bring together sometimes adult pulmonology centers with pediatric centers, and we try to include a lot of adult pulmonologists. I think this was important so that the guidelines are all, the consensus is also used by adult centers. And sometimes you have, as you said, in this kind of consensus groups to make a decision so that you have a statement instead of saying that we do not include the statement at all. It is a sad truth that many, especially adult patients, do not go to the center for follow-up more than once a year. We said that they should be tested as many times as they go for follow-up, but if they don't go for follow-up, they can also not be tested.
We have a comment here.
Well, though I agree with Kim, in practice you have quite a variability in the severity of the disease of the patients. And I think like when you have the CCDC 39 or 14, like you have a lot in Copenhagen, they are generally more severe. And these patients are very motivated to come every 3 months. However, many patients with a DNH11 and very mild symptoms, I have sometimes a hard time letting them come every 3 months. So this might interfere with the, well, what we would like to have and what practically is feasible.
Is that one last question or comment from Lucy? Since we talk so much about adult pulmonologists before we go to
Thank you, Myrona. As one of the small number of adult pulmonologists in the room who was involved in the early version of this, I'd just like to remind us of the dual utility of these kinds of documents and how careful we have to be about the semantics of how we ask each other the questions. And it's complex, but I would just like to make these clear 2 points. One of the goals of these documents is to set up a map for those that come behind us to say, what do we aspire to? What are we trying to set up for our patients with PCD? And in that role, this kind of document is a map. How do we get to the golden lands, the rarefied alpine pastures, the moral high ground of where we think we should be aiming for these patients? And so what Kim and the rest of us did in that first version is to say, we think the golden lands looks like this. It means a patient is seen at least 4 times a year in the perfect world, that they have the earliest diagnosis possible and that you do these tests. And I think even though this is a redo of that map, we're still going for the same aspirational goal, which is to what does great look like for our patients? And if we use these documents in that regard, rather than a echo chamber of how good are we are so good because this is what we do currently, I think that will help us to write the best documents possible. Be aspirational, be brave, be bold, and set a standard for what we think great looks like for our patients, and then work towards it. Because I use these documents to go to my hospital and say, it's not good enough that you don't support us to provide care at this level. This is what the international community says is great. This is what we should be aiming for. And I think we should together use these documents to, to do that.
Thank you for your comment.
Thank you very much, Elora, for the presentation. And I think we can go for a break. Let's aim, I think originally the idea was that we are back at 2. Maybe we take a few minutes more and we're like 10 past because we have one talk less in the next session. So I think we will manage to catch up like that.